we're going to get started as folks are filing in. First off, thanks so much for joining us on your lunch break. Hopefully we'll keep you engaged and excited about the utility of small samples, and you can sustain yourself on that excitement before you have a chance to eat. So we have no disclosures to report. So this is a combined effort to organize this from Vani, myself, and Sarah Yip. You'll notice that Sarah wasn't able to make it to the conference, so I'm going to channel her energy and present the slide that she's prepared when it comes up, and Sarah's quite happy to chat with anyone after the conference if they're interested. So we have a wonderful set of panelists. This was an effort that was motivated in large part by the recent sort of field-wide debate over the utility of small-scale samples, particularly in the study of clinical populations, so folks with addiction, other common psychiatric illnesses. In the era of big data, big consortia, what utility, if any, is there in clinical samples, in small-scale clinical samples? How do we go about designing studies? What types of questions should we consider when we're designing those studies? What are the considerations we should make? That's the discussion we hope to have today. The chairs have asked the panelists to keep their presentations very brief, so it's one slide per panelist, with the hopes that we can have a good discussion for the bulk of the time. That discussion will be greatly facilitated if you can ask questions of the panelists. Vanny and I will push those along to the panelists in the discussion. So please do use the participation app, and we'll ask the questions to the panelists as we go along. So with that being said, we'll get started with the first presenter, so Hugh Garavan.
Okay, hi everybody, good afternoon. Today's presentations, I've just realized there's a typo on my first slide. Well done me. And I only had one slide to prepare, right? You think, how hard could it be? Today's presentations, I think, kind of fall into two categories. There are a couple of presentations talking about the potential benefits of the big data sets and how you might use them to better your research. And then the others are talking about, if you're working with a small sample, how do you optimize the yield from that smaller sample, that smaller study? So mine is very much in the first camp. So I'm just going to talk again, one slide, 1 minute, maybe 2 minutes, about some of the potential advantages or potential ways that you can utilize big data sets. Okay? And as Aaron said, the goal here really very much is to just foster a discussion. So I think we'll all be away from the podium within 10, 15 minutes tops, okay? And then it's over to you. Okay, so there's nothing too deep or profound in what I'm going to present, but it'll hopefully just kind of get the conversation started. So how might one exploit the large end data set? So this is obvious, you could use it, right? It's interesting if you look around the posters, the presentations, I mean a substantial percentage are using these big available data sets right now. It's really noticeable to me how popular they have become. So that's an obvious one. You might need to have a bit of flexibility and creativity because it may not measure exactly what you want, but again, it might measure something similar, something close. It's definitely worth contemplating, even as just kind of an initial step towards what you want to do. So that seems relatively straightforward. You could then use the large end data set to refine your study. Let's be very concrete and very simple-minded. That imperfect proxy analysis you do in the large data set, it might tell you which imaging modalities are the most sensitive for your research question. It might tell you what covariates, what potential confounds you need to attend to. So it can really help, I think, in maybe refining your hypothesis and refining your experimental design for your small study. Okay? So there are things like that I think, the big data sets can be particularly useful. You could harmonize with the large study. So the big study doesn't have your phenotype of interest, but it has an interesting imaging protocol. Personally, I think if you don't have good reason not to, you should probably use the imaging protocol from the larger study, right? There are quite a number of presentations if you look around on like normative data. So there's tremendous advantages in having in your back pocket this very large, well-characterized data. It can help you address a whole bunch of interesting questions. There are all sorts of things that you can do with the large study that are not so easily done with small samples. So if you're interested in developing multivariate classifiers or identifying optimal polyvertex scores or doing neurotypes, or all the sort of sophisticated analytic methods that we're seeing here at the conference, these, as a general rule, require large numbers of participants. So if you can do that with the large study and then apply it to your smaller study, that's probably going to be much more reliable than trying to develop those classifiers, those multivariate approaches on your smaller sample. Again, this may seem trivial and trite, but it's kind of, I think, maybe worthwhile to just keeping these options in mind. There are also, so just I think a whole bunch of additional benefits of large samples. If you have a small study, again, let's make this very concrete. Let's say, make this very simple. Let's deal with reviewer 2, right? Your smaller sample is probably going to have, just by the nature of the beast, potential confounds within it. Reviewer 2 is going to delight in pointing out to you, well, did you control for X, Y, and Z? You probably don't have that rich characterization in your small sample, but if you can then refer back to the larger study and address if X, Y, and Z actually is an important variable for your outcome of measure, having that resource to inform your results is hugely, hugely valuable. Okay. I'm going to finish though with a few of the drawbacks. I think, this probably doesn't need to be said out loud, but I'm going to say it out loud anyway. The large studies, of course, may not be suitable for your research question. If you're interested in, college-age kids, the ABCD sample might be too young, the UK Biobank sample might be too old, and so on and so forth. So that's often a big consideration. The phenotyping is often shallow in these large studies because they tend to want to serve multiple masters. So they might have a measure that touches on the topic that you're interested in, then you say, ooh, but did they administer insert your favorite measure? And they probably didn't. So that's always a kind of a frustrating consideration when you're using these large studies. So be it. And then often, these large studies, they do, I think, tend to be conservative. If you're going to do, I work on the ABCD data set. If you're going to be doing a, decades-long study with neuroimaging tasks, and it's going to cost gazillions, this is not the right time to come up with like a novel neuroimaging probe that you think is really kind of cool. There's just this tendency to go with a conservative a conservative assessment. And then once that study has launched, you're very slow to want to change it. The protocol tends to become a bit brittle and inflexible because obviously you want to get your longitudinal trajectories. So these are obviously some of the concerns and the restrictions of the large sample. I have a feeling we're going to hear more as the conversation goes on. So we look forward to it. Thank you.
Good afternoon. Benefits, limits, and pitfalls of large data approaches. So first of all, I want to preface with saying you need to be clear what you actually want to do. If it's about, let's say, optimizing DMS stimulation in a single patient, you need data from that single patient. If you want to understand something about a disorder, maybe 50, 100 people are perfectly fine. But if you plan, if the goal is to actually use prediction models to tell something about a new individual sitting in front of you, then there's no way around large data. Why? Because the model needs to learn from a lot of people. And we can apply all kinds of statistical tricks. But as long as you don't cover the population well enough, as long as the model hasn't seen what type of humans there are out there, it will not work. This comes with the important caveat that just larger N isn't all that is needed. Recruiting 1,000 more undergraduate students is not going to make your sample more representative. It's my firm conviction that what is shown here on the left, if we want to go in this direction, if we want to do individual predictions of cognitive, affective phenotypes, of psychopathology, if we want to do any of this, we can only do it by training models on large and representative populations that then learn about the underlying neurobiology and its relation to individual phenotypes. And that is the road to the precision medicine. I'm not even sure what this word really means, but everybody uses it, so I keep doing it as well. And on the left side comes, on the right side comes the but. And the but is that we should be very careful in promising that this precision medicine thing will happen anytime in the next couple of years. There's a very long road to practical utility, to something where a clinician, where a patient actually has a real benefit over what is already possible in the clinical setting. And this includes aspects such as, for example, multi-site generalization. Things that work in data that has been acquired at a university hospital may not work at all in data from some community hospital. Last but not least, one of my favorite topics, as some of you have already noted, confounds, bias, and discrimination. I think we really need to be very, very careful inspecting the models and their behavior. And I don't mean that on the technical level, but much more practically. Models love shortcuts. And so, just an example here, if you can predict strengths, predict grip strengths extremely well from MRI data, but if you deconfound by regressing out age, sex, and body size, there's absolutely nothing left. And this becomes an extremely critical topic when you don't have a representative population, or if you have a model that's trained on a population and then applied to a different population, like a model trained on Europeans, then applied to people here in Korea. Because the relationship and the influences of the different confounding variables may shift, and in that case, the shortcut that the model has learned actually turned into a dead-end street. Thank you.
Hey everyone, I'm just going to build on some of the points that Simon made, as well as maybe push back on a few things in favor of small studies, particularly via powerful study designs. If I can get my slides. This one, right? Yep, just turns it off.
You can keep talking, I'll mess with it.
Cool. So, while the field, I think, has gotten really good at cross-validation and out-of-sample predictions, what you really need for utility is out-of-temporal predictions, right? Trying to predict future time points in terms of trajectories and change scores and things like that. In mental disorders, a lot of these diseases are varying temporally, right? So the power dynamics change. You don't need as large samples when you're predicting trajectories and change scores. And I have a really great example of that on the next slide, which I'll come back to. So you'll have to believe me that that is the case. So the prediction target matters, not just temporally, but the content of it, and that requires domain knowledge. And one of the best ways to do that is to engage people with lived experience in choosing your prediction target, right? That actually matters and maps onto neurobiology better. For example, with Psychosis, in the trial, which I'll show you in a second, that we designed, when we asked young people, what should the target of this trial be? It wasn't symptoms, it wasn't cognition, it was functional outcome. Jobs, familial ties, education, social relationships. And obviously that automatically boosts the clinical utility of a trial, but it actually mapped onto neurobiology better. And once again, we could predict it using baseline base data up to 12 years at a R of almost 0.5 correlation between actual and predicted change. We couldn't do that with symptoms, and we see these tens of thousands of studies that can't predict symptoms in mental health. It's partly because we might not be actually mapping onto what's important, and that maps onto neurobiology. It's not just more clinically useful, it's more real in the brain. And we don't require necessarily hundreds of studies for that, hundreds of subjects for that, or at least thousands. Setting up channels for lived experience can be hard. It's a lot easier said than done to engage people in your study who have domain knowledge, but it's not just lived experience. You can do experience of loved ones, labored experience through working, with patients, as well as learned experience through studying phenomenology. Maybe the click. Oh. Yes. So here the SOPHOS is a functional measure, and we're using baseline structural connectivity data. We could predict that really well, cross-validated in a sample of how someone's functional outcome is going to look like. Are they going to get worse or recover or not at 12 months? And in terms of domain experience when designing your study, lived experience is crucial, but it's not just that. There's learned, loved, and labored experience as well. And I would recommend this review by Owen Kalecki in Lancet, which really summarizes domain knowledge in psychiatry and how you can leverage it to maybe pick a better prediction target than what we've been doing. And this one I'm not going to spend much time on, but what I've learned over my brief time in this career is that clinicians will put far more weight on an N of 60 trial than they will of an N of 600 or a 6,000 observational study. When you powerfully modulate an organ using a drug or an intervention, it's much easier to study, and that's why they believe that more. Whether that's good or not, that's for you to decide. Obviously, easier said than done. These trials are expensive and need big teams to do. But these trials are already happening in neighboring departments in psychiatry, neuroendocrinology, endocrinology, addiction medicine. So why not spend our time, money, and experience lobbying to add imaging to these powerful, small clinical trials where you can disentangle causal mechanisms rather than repeatedly pumping out large observational studies, because you can get at causality when you control, right? But again, I acknowledge easier said than done. And the final point I'll make is a little bit more practical. Regardless of study design, predictions with imaging will only be useful if they're accurate, and accuracy is hard in smaller samples more often than it is in larger samples, as Simon clearly stated, right? So Thomas Yeo and his team at the National University of Singapore have developed a method called metamatching, where you can train a model on a very large data set and then apply it to smaller data set to boost predictions, even if your phenotypes don't match between the data sets. And I won't go into the methods too much. This works because the brain is massively degenerate, right? The same circuits that predict one phenotype will predict a broad range of phenotypes, right? You can lose 80% of gray matter in certain disorders and still have relatively normal cognitive function. So using this, we have boosted performance in small psychiatric samples less than 200 people of cognitive function, cross-sectionally, not longitudinally, as well as generalizability. But in the interest of time, I'll kind of just finish with the final thought. What R-squared value, mean squared error, R-value, confusion matrix would be needed in the behavior or disorder you study for it to be clinically useful? It's a really hard answer to get. There is no studies in psychiatry that are asking clinicians, what is the R value? These only exist in neighboring departments, in hematology, in oncology. They have these answers. So we need to start looking back on our field in psychiatry and asking clinicians, what is the R value for this particular disorder that would be relevant? And I'll end it there.
So as I mentioned at the outset, Sarah Yip was unable to make it. She had a delay on her flight, and then was unable to make the transfer flight, and then wasn't able to make it to South Korea. So for folks that know Sarah, just pretend I'm Sarah Yip for the purposes of this talk. So this is a graphic from a review paper from Sarah's group on clinical predictive modeling, in which she proposes best practices and also emphasizes that the identification of biological mechanisms must be at the forefront of any clinical MRI study. So there's no need to go into all the steps here. What she wanted to highlight are 4 key aspects. The first is that you have to carefully consider your outcomes of interest. So not all treatment outcomes are created equal, and simplistic outcomes such as yes, no to treatment response can obscure your ability to look at critical individual differences. Dimensional outcomes embrace sample heterogeneity to improve prediction would be ideal if possible. If possible, you should use biologically verified or clinically verified definitions of treatment response that are based on repeated assessments over the course of treatment. The second is careful consideration of the timing of scanning. So typically, scanning occurs prior to treatment, and that's thought to be ideal. This can introduce a lot of unnecessary confounds and analyses. So for instance, in the area of substance use, which Sarah's work focuses on, there can be effects of acute intoxication, or in case of work in my lab, if you're studying psychotic illnesses like schizophrenia, there could be the effects of acute psychosis. So scanning prior to treatment onset could be okay, just as long as you're careful to consider how this might impact the interpretations of the data. The third thing that Sarah wanted to highlight is the critical need for post hoc testing to understand the relative importance of different model features and to guide interpretation. So within this context, it's important to consider model findings across multiple levels of interpretation, with the most basic level being connections themselves, and the most abstract being a overarching neurobiological model, which can be used to guide treatment development and act as a basis for further testing. So without those findings from models, even those with high accuracy, they may do little to advance actual clinical utility and understandings of the underlying neurobiology, which are then essential for treatment development. And finally, just to emphasize that this should be considered an iterative process. So results from a given smaller scale study should be used to refine the design of the next clinical data collection initiative, which is crucial if you're thinking about the generation of large consortium data sets. Without an iterative refining process from small scale data collections, there will be no progress in the design and implementation of large scale studies. So once again, Sarah apologizes for not being able to make it. Hopefully she'll catch up with everyone at the next OHBM in Brisbane. Thank you, guys.
All right. So building off both Avram/Sarah and Sid's talks, I'm going to be talking about dense sampled neuroimaging and phenotypes, more so than prediction-based. So as most of you probably know, dense sampling is this accrual of a large amount of data in a small number of subjects. So the reason that we do this has to do with 2 different paths. And as a clarifying point, I know this is a neuroimaging conference, but this data doesn't have to be neural data, right? It could be behavioral data, it could be physiological data, or it could be any combination thereof. This works in all contexts, right? So the first path that we can use this data with has to do with a longitudinal type analysis. So longitudinal analyses let us get more at the trajectory of clinical disorders. So for example, substance use disorders are known to have different trajectories of treatment, like remitting use, sustaining use, cycling use. This can also help us get more at whether or not certain symptoms of disorders are trait-like or state-like, something we've had a hard time parsing out so far. Now, the second path that we can use dense sampling with is this idea of really precise individual data, right? If we pool all of this data together, you have so much data per person that you can get really, really precise neural maps or behavioral phenotypes that can be very useful in clinical contexts. Now, as we're talking about potentially increasing the power with this small n, I want to talk more about the heterogeneity and how this can be used in different ways as both positive and ways we can control it with these within-person designs. So my first example has to do with the heterogeneity both within subjects and between subjects. So cross-sectional analyses introduce a lot of heterogeneity, right? You have genetics, experience, brain size, example here, hormonal levels, right? And a lot of this we can control for. Some of it we can and we don't, right? Hormonal level is a really easy thing to ask somebody about if they're where they're at in their menstrual phase, and it's not something we do, even though it's a very clear physiological tie to neural dynamics. So if we do a within-person subject study, right, a lot of that variation just goes away. You have no variation in brain size, genetics, experience, and some of that we can actually put into our model as essential dynamics that can help us increase the signal of these dense sampled subjects, such as hormonal level, menstrual cycle. This can really increase our signal, right? Now, the second example I wanted to talk about, it has to do with our measurements. So for example, tasks can sometimes be criticized for having lower test-retest reliability. And I think a part of that might have to do with the fact that when we do these kind of cross-sectional between person designs, we're not really picking up on the fact that they might be studying states, right? And so by doing within-person studies, we can really see how variables co-vary together and distinguish between noise and state changes. So I really think that dense sampling has really strong implications for clinical research that cross-sectional work really was never designed to get at. As for that first path I mentioned, the longitudinal path, right? This path can be really good for getting us to look at critical within-person dynamics. These can even be manipulated dynamics, right? Like starting a study, introducing a new treatment, and continuing the study. And this gives us a really strong signal because we know exactly what's going on. But also, a lot of psychiatric disorders have their own manipulation inherently kind of within them, right? So some disorders are very, very dynamic. By doing within-person studies, we can really get at how those dynamics in our data align with critical transition points, such as depressive episodes or shifts away from abstinence and addiction. And together, this can help us figure out treatment transitions and whether or not treatments are going to be successful. As for that second path, so looking at that really, really precise, individualized data, right? This can be, I think very clearly, a very, very beautiful picture of one person's neural data or behavioral phenotypes, right? And in doing it that way, we can more so get at things that are clear, stable characteristics of maybe a prognosis of disorders or distinguishing disorder subtypes, or again, understanding whether or not one treatment is going to be more successful than another treatment based off of these really, really precise understandings of one person. So all in all, I really think dense sampling has a lot of clinical implications, and I'm excited to talk about it more at our roundtable.
Hello. Hi. Regarding the clinical or practical utility of fMRI, this is the question that oops, how can I go back? Okay, this is the question that I've been wondering. And as you know, we have certain concerns about fMRI, like its low reliability. Reliability is, as you know, important because it's essentially the upper limit of what we can predict with a measure. And the we need a lot of samples to achieve good performance according to previous studies. And there's some possible promising, some potentially promising or better approaches for analyzing fMRI data. Like within a single person, it's actually easier to make good predictions on certain temporal domains. And as you know, machine learning or AI can help, but not as much as you may think. We can possibly train on a big data and make predictions on small samples, like Sid mentioned, but this is an ongoing approach. And I think we essentially need to use better features. We need to use assays and probes that can actually evoke the processes that we are targeting. Like, we use like movie watching instead of resting state. So, like Francesca mentioned, I think it's important to combine computational and behavioral phenotypes into neuroimaging data analysis, especially because those behavioral and computational features are actually can be used in combination for fMRI data analysis, like model-based fMRI. And as you know, behavior features often outperform neuroimaging features when making predictions, like from Hughes' former previous paper. And computational modeling can reveal latent neurocognitive features that can actually be useful in many ways. And actually, a recent study actually suggests that with generally modeling or computational modeling, we can dramatically increase the test-retest reliability. And however, with the current technology, we still have to use like several hours to extensively cover all the RDoC domains of, let's say, substance use disorder patients, and then it's just too demanding for a patient to participate all those essays and tasks. So recent studies, and including my own, suggest that we can use Bayesian optimization algorithms to reduce the number of trials dramatically, and at the same time, increase the reliability. So this is like a study that shows that we can increase the test-retest reliability quite a lot, and we can save the number of trials or shorten the test duration by doing a smart study. And studies suggest that increased reliability or better statistical or computational approaches can also increase the reliability of the fMRI measures. So we can possibly use those approaches to do some computational fingerprinting or like fMRI-based fingerprinting if we can actually do a better job with those tools. And I think it's important to combine like theory-driven like model-based fMRI and data-driven like machine learning or AI, because each approach has its own benefits, but few studies actually have combined both model-based fMRI and machine learning. Lastly, I think it's really important to use real-time, real-world tasks to evoke more the target process that we have in mind, and so that we can also increase the ecological validity of the tasks that can possibly increase the predictions from the multimodal data. Thanks so much.
Okay, hello everybody. I'm Vani Pariyadat. I'm at the National Institute on Drug Abuse at the NIH. First off, I just want to thank all our panelists for an amazing job setting the stage for our discussion today. And I want to encourage all of you to use the app, or please just come up to the microphone to ask questions to the panel. And while we're getting started on that, we're going to start with just a question to all the folks here. Essentially, where do you see the value in small N studies?
Well, maybe I just repeat what I started my talk with. It depends on what you want to see, what you want to study. So there was also the question about the N1 case studies, case reports. If you find a patient that has a specific lesion or a specific syndrome that tells you something you thought was different about the brain, then N equals 1 is fantastic. If you optimize the TMS hotspot stimulation, then N equals 1 is fantastic. If you go for a phenomenon that has a relatively high effect size, and if you're not interested in inter-individual variability, but in the general phenomenon, then 30, 50 is usually absolutely fine. I mean, it's not like we need to throw everything out of the window that has happened over the last 30 years. But if you are interested in inter-individual variability, then you need enough subjects to actually allow your method, your algorithm to learn variability. And you can't do that with 50, and you can't do that with 100. Humans are really different. And as long as you don't expose your model, your algorithm, to this big variability, it will learn whatever, but not what you want.
Yeah, I would agree with that. The only things that, let's say, come to my mind, we haven't talked about effect size, but clearly the sample size you need is going to be related to the effect size. So if you have a very powerful effect, if you have a clinical sample and you're doing, let's say, within participant drug treatment, that might be absolutely sufficient. There was a nice example provided at the neurosalience talk yesterday. If you are studying a phenomena that, kind of counter to what Simon was just saying, that you believe truly is a universal, so retinopathy, if you demonstrate that really well in 1, 2, 3 participants, that might be more than sufficient. So I think there are places where the small sample is absolutely sufficient.
I also think, just from like a really, really clinical point of view, right? We know that, like, for example, depression has like 13, unipolar depression has like 13 different subtypes plus, right? And in addition, there's like 20 plus medications you can give for depression. And within that, we don't even know what these individual diagnoses really are, because there's like a 30% likelihood that if you go to another doctor, they're going to diagnose you with the same depression. That being said, what I'm saying is, like, each kind of individual with a disorder has very specific, individualized aspects. And so I think that's really important when you think about the clinical utility of small n studies.
I think flexibility is the main one of the main advantages of small n study, because like if you think about human connectome project, ABCD study, my lab also used the data set and tried to publish papers, but then there's only a few fMRI tasks in that data set, and the task I want to use and I want to administer to my participants isn't really the task in many cases. So with a small n study, I can use the task that I want to use and use the most well designed for my own study, for the study that I want to conduct. So, I think that's one of the keys for small n study.
Completely agree with everything. It completely depends what your small study, what the aim of it is. But one other one that I don't think has been mentioned is a small study can be very useful if you've sampled the full range of variants, right? And obviously that's very hard. But for certain behaviors, it's not as hard as you think to oversample on tails, such as going across diagnostics categories and looking at extremes of behavior. You can build much better prediction models with much smaller data sets. We've just released a small transdiagnostic open data set on Open Neuro, which has dense sampling, and we've demonstrated it in this data set as well. So, yeah, that's one point.
There's a question at the microphone.
Thank you all so much for your talks. Those were really, really inspiring and interesting. I'm curious if you have any thoughts on what you think are the most significant technical or scientific limitations that are preventing researchers from being able to increase the density of behavioral sampling without overburdening participants. What's preventing us from being able to do that?
Can you repeat the question one more time, maybe in a different way?
Would you mind repeating again, maybe rephrasing?
Yeah, sorry.
Slightly? I think it wasn't
make it
clear.
loud?
Sorry.
Sorry, I'm pretty verbose sometimes. My apologies. What do you think are the biggest hurdles preventing the field from being able to increase the density of sampling behavior in subjects without overburdening our participants? Thanks.
Well, the problem is the without overburdening. I think one direction that may become very interesting in that domain is the use of mobile devices, smartphones, maybe wearables, smart watches. So you can actually get quite a lot of behavioral information passively. Plus, if you don't put somebody in a test room for 6 hours, but rather have them do some tests twice a day, for example, like we've been doing it for Parkinson's and others. You can actually do quite a good sampling without overburdening, but obviously there are limits to what you can sample in a remote setting.
I work with the ABCD data set, and all my answers are probably going to relate to the ABCD data set. I've drunk the Kool-Aid. But one thing, for example, that has come through there is geolocation data. So I believe we have now linked the current and former addresses, well, current address of our participants to at least 70 different databases. So you can get really useful information from pollution, vegetation, proximity to liquor stores, crime, and so on and so forth. So you can get very, very rich characterization of the lived environment of participants, and all you need is their home address. So I think that's just another example, I think along the lines, no burden, but rich yield.
Maybe I can reiterate some of the things I said in my slide too. Behavior tests are very long and demanding, as you may know. So with the Bayesian optimization like ADO, by asking the right question on the fly on every trial, we were able to minimize reduce the number of trials and shorten the task, and also increase the reliability, which is really a problem for many laboratory tasks, as reported in many papers like Paul Drake's group and many groups. So with the ADO and with the mobile technology, although I didn't show it here, we were able to actually use the ADO-based tasks on a smartphone on a daily basis, which is actually feasible because we are using ADO-based, and we don't ask participants to complete 100 trials. We just ask them to complete just 20 trials. So I think it's one of the ways we can possibly make it possible, along with many other approaches.
I mean, one of the more practical limitations as a junior researcher is funding and short-term contracts, right? A lot of these dense sampling methods are being championed by a newer generation of researchers that are moving around with less funding. So there's actually practical limitations for us who want to implement these dense samples to actually do that, hence why we rely on these bigger consortiums.
Thank you so much.
Online?
Yeah,
Me.
go for it.
Okay, so I mean, when it comes to data and when it comes to generalizability, there is no data set big enough, right? There's always going to be some hidden variance you can't sample from the big data sets with their shallow phenotyping versus the smaller data sets with deep phenotyping, but not sampling the relative populations. And so it really becomes about the synergy between the two, right? The smaller data sets allow us to shine a light on what features are useful and develop classifiers even with n's of 50, 60, or whatever. It still brings something useful to the table that can then be exploited and repeated around the world. And ultimately, it comes down to what's the question we're answering, what's the relative sensitivity and specificity for that particular question, and how does it change our probabilities. And certainly in the biomarker world, there is benchmarking, right? So you train up something, and then in your local area or your local part of the world, you then test it and optimize it to those populations. And I think maybe that sort of approach can be used with both.
We agree to agree. A question from the app. How do you consider excluding subjects, quality controlling data when you have a small N study? I'll just add to the question and say, particularly in the context where it tends to be the most difficult to recruit participants, perhaps the ones with the most severe pathology who tend to have more issues with quality in the data sets.
I know it's a difficult question to answer, but for sure, I think you have to actually spend a lot of time and energy thinking about quality, a lot more than people working with larger data sets do. Go into creative tools, look at ML methods to improve data quality before you go into whatever derivative that you're using. But it's just, yeah, you have to focus more on it. There's no way around it. You can't just, unless you can acquire more data.
Let me take a little bit of the opposite point of view. It's actually a feature, not a bug. So no, you should not exclude people in small n studies, because in the end, if we really want to move towards clinical application, we cannot say to a patient, oh, we don't know whether you're going to relapse or not. Your data was not good enough. We excluded you. So I think it's just part of the ugly reality that in real life we don't have HCP quality data, and we have to work in order to still get something out of it. And that, since it can't be on the data side, then needs to be on the analysis and modeling side.
I think also like a pro of dense sampling, for one, right, is it doesn't really matter all of the time when those data points are received, right? Like if somebody says, I can't come in right now, I am homeless, I can't get out of bed, like whatever. You say, okay, let's come in a week. You incentivize, right? Incentivization is really, really big I study addiction, right? So we have a lot of issues with homelessness and socioeconomic status. So I think like incentivization is a really great way to help ensure some of those issues. And then also, being flexible in moving the times. And I know that's sometimes hard with MRI booking times. But in general, the time point is not always the most critical, as long as you're flexible to your subject.
So I think we're going to switch back to questions from the microphone, so go ahead.
Thank you. Since I'm an engineer, so I'm support for artificial intelligence. So I believe like foundation models will like finally be the winner on the clinical utility or other predictions as its success in the protein field. But what's your opinion and attitude about the foundation models in neuroimaging? It could be like for brain disorder and other general neuroimaging downstream tasks. Because no one, I think, really take care or thinking about this.
Sorry, can you clarify what you mean by foundation model?
Yes, in general, in the language, it's like GPT, but in other tasks like vision, it could be like training a very big model, and then you can get other downstream tasks like segmentation, prediction, classification. Yeah.
So I just briefly mentioned that approach in my talk, and I think it's one of the very promising approaches many people are interested in, like train on a big data set like ABCD, HCP, and then use the outputs as prior for analyzing the smaller data set. I think this is kind of an unexplored area, transfer learning, and I hope many AI researchers and neuroimaging researchers can actually develop some better tools so that it can actually benefit many other researchers. So, but this is one of the areas that I'm also working with my collaborators. Although I think Sid may have something to say.
I didn't actually hear the question, but yeah, that is definitely a really important way to go, is to why not borrow information from these large data sets? It's already there. The correlation structure of what we want to predict maps onto the correlation structure in these big data sets. But that will only work if there is some sort of overlap between the small and large data set. You can't have a large data set trained on age, sex, and race and use it to predict something like cognitive function, and it might work, but it's not always the direction we want to go in. So we want to make sure that these large data sets have deep enough phenotyping that they cover a lot of use cases without becoming too problematic.
Okay, thank you.
Go ahead.
Thank you to all the panelists. I think, yeah, this topic is the most interesting for me, so I'm really glad to see so many amazing thoughts on the topic. I work in computational psychiatry, and my interest is cognitive tasks and computational modeling of those tasks and how we can use that to predict treatment response. And when it comes to sample sizes and running studies, I wanted to ask you about basically the first step in this process, which is psychometric validation, and how we can do those validation studies I suppose, with smaller samples and make them as informative as possible.
Don't validate only on psychology undergraduates. No, seriously, it's a big problem in the field that even more for these validation studies, pilot studies, and so on, we trend to use convenience samples, and the most convenient is usually psychology students. So a lot of psychology is on 20 to 22-year-old, high-educated people from usually quite okay backgrounds. And if you want to use that then in a 45-year-old homeless with a drug problem, you may be in for quite a lot of negative surprises. So meaning that from the start, and in particular also when you do these kind of validations, be very aware of your sample characteristics. They should match those where ultimately the task is being used.
Could the panel maybe speak to the issue of maintaining a representative sample if you're collecting a small data set? So what are the considerations you think of, and how do you handle things like cross-cultural, cross-population representation?
I'm not sure how to answer it. I think teeing off of what Simon just said, I don't know that you can. I think that's the struggle. And I think that's kind of the essence of his response to your question. You know, validating with 50 people so you can roll it out then in 10,000 is in some regards maybe backwards. One of the beauties of the large samples, I mean, representative is a difficult word, what's representative versus not, but in a diverse sample where you can see if the phenomenon of interest, you know, works in whatever subgroups of the population you think are pertinent here, be it race, ethnicity, and so on and so forth. Like, I genuinely don't know how you can do that. So this is a question, let's just throw it back at the audience. I don't know how you manage to do that if you have an a priori reason to think that this measurement might vary across subsets of the population. How do you address that with a small sample? It almost seems like an impossible chore to me.
Let me be a bit positive. If later your main study is going to be focused on a small subgroup of the population, then piloting, validating in a close enough or in the same subgroup may work. But that comes with a caveat, and the caveat is your measure, your model is then only for that subgroup. That is maybe good. Maybe that's what you want, all you need. But it's not something that you can then easily also use in a completely different population where it wasn't validated.
I think also like a big pro of small N studies is you can kind of be picky about who you are choosing to be in the study, right? Like you get the most power from the most dynamic people, right? People who are on the farthest end of the disorder spectrum, right? Who have the most dynamics in their behavior. You can pick that. You can pick people who might be historically underrepresented. You can be kind of picky to make sure that you're like getting the representation that you feel matters the most for this to be both highly powered, highly applicable, and clinically utilizable.
I also don't have good answers for the question, but this is one thing I tried. So to validate a approach like ADO, what I did was first try undergraduate students. It worked, but then I tried patients with substance use disorders, worked, and then what's the next question you would ask? Maybe Amazon MTurk. So we ran Amazon MTurk workers, over 700, it worked. So I was convinced that it works. So maybe that's one of the things. Yeah, maybe students, populations, MTurk workers, if you can. If that works, I think, yeah, you can be pretty sure.
Just building on what Simon said, generalizability is important, but some of the best models in medicine that are useful are center-specific. Hospitals have their own prediction models, right? So having lots of different non-generalizable models is still a very useful path forward as well.
Thank you.
We're going to switch to a question from the app, and then we'll alternate back to the microphone. This one's directed at Simon, but I think others might be interested in answering this as well. From a group who say they're getting really good brain age prediction results from a sample of 55 clinical individuals, and they're asking what recommendations or suggestions you have then for small N studies in general that want to use prediction models.
Well, I assume that was cross-validation accuracy within the 55, and that's good. Congrats. Now, use a different sample. Use any of the available data sets out there and see whether it generalizes. Most likely it will not. Why? Because you can have a very good model for that particular population. It seems we are sort of circling around the representation topic again. But you can have a really good brain age model in that 55 people, and that may be the population you're interested in. But will that model work on, in inverted comma, everybody else? Most likely not if it's trained on 55. It just hasn't seen enough of the world.
In my personal opinion, it really depends. However, if we have more money and more resources, I would go for more samples because I think in many papers, like a paper from Tor Eggers group with Wu et al. 2017 Nature Neuro, they show that with smaller sample size, there's a greater risk of mistakenly over predicting good accuracy. So, and with larger sample size, typically accuracy goes down in many different reasons. And we typically have to do also cross-validation. And with 55, NO55, it's kind of tricky. And like tenfold, fivefold, it's not really large enough. So to really publish in a good so-called good journals, I think you need more samples, and also to identify the feature importance or what are the important features that actually contribute to predictions. I think the more the better.
Can I just add one quick caveat? Maybe this is brutally obvious to everybody, but we are talking here primarily about the search for individual differences. If your goal is to just map a psychological process, good old-fashioned neuroimaging circa 2000, 55 people is probably plenty to get an activation map. There's all sorts of ways that you can demonstrate that.
I agree, yeah.
It's really in the context of individual differences or maybe case control comparisons where the sample size is most pertinent.
Maybe a question for the microphone.
Thank you so much. Very interesting discussions here. I just want to, it's related to the question that just came before me. I'm not going to ask too much about the neuroimaging side, but on the outcomes, because usually we relate our neuroimaging to outcomes, and I felt there's a bit of a gap in looking at methods within the structural equation modeling framework, because we have within SEM a lot of tools that both can utilize the Bayesian kind of methods, but also all of these things that we talk about within the variation and also the dense sampling, which could be really utilized, because in the end, we're using statistics, and as much as we can reduce, the measurement errors, this is where actually we can make a difference. If we're able to reduce the measurement errors, then we improve our analytical power, even if we're researching very small effect sizes. And so things like comparing validations and also the question about psychometrics, we have measurement invariance that we can test across different groups. And then we can also model the measurement error. But I feel it's lacking in discussions that there actually are tools now to integrate lots of tasks that we are picking up, which are all proxies. And so they all come and add to the error term in our analysis. So I'd like a little bit more discussion and comments on this, because there are actually tools to address some of these issues that we discussed today.
Excellent point. Actually, I think we should be worried even more about our phenotypes than our brain imaging data. So there's a there's a paper that a student of mine, Martin Gell, presented here last year that's now on bioRxiv, and you basically showed that prediction accuracy massively depends on phenotype reliability, to the point that if you get a phenotype that has a reliability of like 60%, then basically no N can save you anymore. So the key point here is we really, really, really need better, more reliable phenotypes if we really want to move forward. That, to me, is probably the number one cure, clearly above large sample sizes.
Yes, I agree, very much so. I think there is something great to be said about tasks, right? And that for the most part, they're very, very theory-driven. And we know that theory-driven tasks can really increase signal in MRI dense sampling studies. There's this opinion paper called 2 Paths Towards Reliability, and it basically talks about this whole thing of like dense sampling and consortia and how they're both like great methods. And there's this great part of it where they talk about how if you have a task and this task has a theory-driven background, you're going to increase your signal and you're going to increase the power that you can have. I also think specifically in a clinical side, right, people with psychiatric disorders can sometimes have a harder time with self-introspection. So when we do our questionnaire type analyses of phenotypes, we're often not capturing what like the reality is of their phenotype, only what like they think it is, and they may not actually know how to communicate that reality, and tasks can kind of sneak behind that, right? And like directly seeing how their behavior is rather than how the subject thinks their behavior is. And I think that is a great way to have higher power.
Since everyone's dropping reviews and commentaries, there's a beautiful commentary called Pulling, like I think the title is Pulling on the Wrong Lever by Jeg and Tiago, basically saying exactly what you guys have been saying, is that we're pulling on the wrong lever to boost brain behavior correlations, should be focusing on the phenotypes. But you mentioned SEM, and it's a beautiful framework for explaining variance, yet I'm yet to see a single study that's using it to generate a useful prediction, a future prediction, a trajectory, right? A cross-validated model. Maybe that's out there, and maybe I'm wrong here, but I think if that framework can be used in that way to prospectively predict, it could be very powerful.
May I?
Yeah.
Okay. Once started, I can't stop. No, I just want to tee off of what you said, and there's also a question here in the chat about, why are we talking so much about prediction? So like this issue, part of the reason why I'm delighted to be part of this, I don't feel like I have an awful lot to contribute, but like this is a very current issue. I have a colleague who has a K award, and one of his aims was to run 80 participants and compare those who have anxiety disorder against those who don't in your classic 40 subjects in each sample, case control comparison. And he has been asking me and asking his program officer, should he go ahead and do this? It's not an easy question to answer. And I have to say, like, I'm inclined to think that he shouldn't. And what I think maybe he should do if his program officer, I keep looking at Vani, she's not his program officer, but it's one of her colleagues, is he should, this is sort of teeing off of what you're saying and sort of teeing off of what the question here, is he should probably use those resources to study the phenomena better. So if he's interested in anxiety, instead of trying to do a case control, and you had said yesterday, Simon, in another context, that people should just not do those studies anymore, like it's not that interesting. Do a really, in-depth, whether it be with the structure equation modeling or just better cycling, but really maybe use those resources to change your question. Maybe 40 versus 40 is no longer a useful use of resources. That's a bit controversial, but there you go. But instead use the resources to understand your phenomena so much better and come up with a better task, a better probe, better analytic approaches to the data.
Yeah, that's a good point. It goes also to the issue of dichotomizing anything anyways, even statistically, and I think psychiatry is moving a little bit more on the spectral kind of aspect, which kind of helps us look at, individual variability. But thank you very much for your comments.
We'll go back to the microphone again.
Hi all, it's been such a riveting discussion, thank you so much. My question is more on the use of advancements in the AI field itself. So the introduction of explainable AI models, and also the introduction of humans in the loop-based, feedback-based explainable AI models. So basically in this, domain experts or even clinicians kind of look at the model outputs and evaluate the model outputs based on what features they're kind of using to classify or to predict. And then the domain experts are kind of used in the process of training the model as well. So do you think the field of neuroimaging and also clinical neuroimaging, do you think this field can benefit from such a kind of an advancement in the AI field? What are your thoughts on this?
Well, I think we definitely will ride on the advancements in AI that are yet to come or that are coming. But I actually found a side note you made, much more important, which is get the clinicians in early, because in the end, they and only they can decide what is useful. Is it going to be a prediction? Is it going to be a score? Is the kind of acquisition just not feasible in their daily routine? And so on and so on. So I think we really, really, really need to get away from a pure biomedical engineering, data science approach, and back to looking at the brain, at the patients, and also tying in those people that really are the users in the end, because you will not be the user that potentially actually has to deal with the output and explain it to a patient. And that's another point we heard a couple of times here on the conference about explainable AI. I'm always a bit giggling because it's explainable to a data scientist, explainable to a medical doctor, or explainable to a keeping with that example, 45-year-old homeless person with a drug abuse that still wants to know, why do I get this medication?
I agree with what Simon said completely, and I also think AI, machine learning, those technology will greatly help the researchers in the field. But at the same time, again, I think both AI or analytical methods and developing better features, better inputs to the AI algorithms, I think both are important. So I think better collaboration between experts in AI and experts in the clinical or domain areas is essential to advance the field. So I just wanted to highlight that.
Taking a question from the app. What should be the requirements to publish small-end studies? So should they be required to reference larger data sets, generalize their models? Should those requirements be done by the publisher, by the funders? How should we treat discoveries from small-end data?
There should be no blanket rules like that. It would be extremely detrimental. It completely depends on the purpose of the study, and you've already seen great examples here of small-end studies that do fantastic outputs. So I think blanket rules like that wouldn't necessarily serve the field very well.
Fully agreed. Every paper should be judged on its own merit, and unfortunately, many small-end studies have little merit, but also many big-end studies have little merit. So in that case, no, absolutely not any of these blanket rules, I agree.
Hi, thanks for this discussion. That's great. I'm Tim Rittman from Cambridge. There was a question earlier about how we improve representativeness and heterogeneity in small N studies. Can I suggest that one approach to that would be to ensure that people who are looking at the same sort of questions are doing the same sort of MRI sequences, for example, an approach. I work in rare neurodegenerative disorders in the tauopathies, and we tried to do that across the UK, which has been reasonably successful. We're starting to do the same sequences as they do in Germany now as well, through the sort of Munich group. But how can we better do that on a global level? Is that something that the OHBM should be sort of supporting? So how can we make sure that people who are doing the same sorts of studies are using the same sequences?
I don't know the exact answer to that, but I do know that there are groups of people, right, who fully agree, and I agree, that we need to start joining as like a group, as OHBM, and to create like stepwise methods for the same types of studies. So Ahmed Ekatari at University of Minnesota in the United States has like a great working group on TMS and making sure that almost all TMS studies are trying to use the exact same like methodologies so that we can make sure that they are clinically comparable across locations. So I think what you need is basically one person to be like, I'm gonna do it, and join forces with then everybody else at OHBM and be like, we're gonna do it. But having one person who's going to do that is hard, and it won't be me, I'm sorry.
I don't know. This has come up a bunch as I work with the Enigma Consortium, and which is kind of legacy data and secondary analysis. But there's often a call from the investigators saying, "Hey, we're about to do a new study. Is there a way you would like us to do it for this very, very reason?" But it's not, to my knowledge, included in, let's say, grant review. Why are you using this atypical sequence without justification? Why aren't you using a more standard harmonizable sequence? And I don't know if that's on the radar necessarily, he says, looking at his NIH colleague. But it seems like it's a really important point, and I don't know how you institutionalize that and make that happen, but I think it's a really important thing we should really try to do.
Thank you.
Another question at the mic.
So there was a question earlier about can we use something like in machine learning? There are large, very commonly used standard visual models that people use for all kinds of tasks, and whether we could do something similar with neuroimaging data or other types of neuroscientific data. And I remember seeing a paper. I think Steinman was actually an author in one called meta-matching. Where they take the UK Biobank, a model trained on a UK Biobank, and apply it to a smaller data set, and show that it works with your imaging studies as well. But I thought that was like a revolutionary paper, revolutionary method for linking the smaller end studies and large data sets like UK Biobank. But I mean. But we're still having this talk, right? What has been the limitations of that method for small N studies?
Well, I'm happy to agree it was a revolutionary paper. Unfortunately, I also know the limitations. No, the limitation is that ultimately this is different from foundation models in other areas, because what it mainly exploits is the low dimensionality of human variability. So basically meaning that most phenotypes are to some degree or other correlated with each other. So when you train to predict 50 different phenotypes on a large N study, then basically your target phenotype in a small n will have some relationship to these 50 phenotypes. And if that's the case, then you can either do a direct transfer, or that's what we're doing nowadays more, you can actually do a stacking model of the output predictions. That, however, is all dependent on there being a correlation, univariate or multivariate, between your target phenotype and the phenotype that the foundation model was trained on.
Yeah, that's exactly right? The performance boost of meta-matching is exactly correlated to the correlation between your small phenotype, the phenotype of interest in your small data set and big data set. What I showed there was a prediction boost of cognitive function of a meta-matching model trained on the UK Biobank applied to small data sets. The UK Biobank has a large amount of cognitive tests for a data set that big, so that works. But the second you try to use it to predict something like hallucinations, mood, or anxiety, it doesn't work anywhere near as well.
One small point too. A lot of the big N studies, right, are BWAS studies, can get compared a lot to GWAS studies, the genetic ones. And there are some papers that have shown that the GWAS studies have gained a lot of power by using the high-top hierarchical model of psychiatric symptoms rather than the like DSM's archaic diagnoses. And I think that's a great way to kind of, I don't know entirely about this, but I feel like, based off of what they said, that's a really great way to kind of bridge some of those gaps, is like adapt to a hierarchical model of psychiatry.
We're at time. So briefly, before we close down, we've talked about some of the limitations of small N studies. I'd be curious to hear the panel's best argument, briefly, say in a grant, for why a small N study might be important. What's your case for case studies?
If your intervention's powerful enough, such as an antipsychotic, a psychedelic, or a brain stimulation, then that overpowers the need, and you can get at causality with a powerful intervention plus experimental control.
When you want to map a general phenomenon, then you can do it in 30, 20, 50 people. Like, I don't think there's any argument for group analysis below 20, to be honest. But if you have a robust phenomenon and you want to find the common thing, then it's good. But when you look at individual differences, then there's not much argument.
You're taking all the good ones. Let's see. If you have good normative data, so you have an interesting case study, and you can probe, where you know what the normal population variation looks like, that might work. I think the stuff that's been mentioned, and what was in response to one comments, I think the deep phenotyping that you can do in a small sample is something you can't do in a large. So that's an obvious, I think, benefit as well.
We need large N studies, of course, but what kind of assays or tasks you're going to use for the large N study to make decisions about the paradigms, tasks, we need small N studies. Otherwise, we're going to waste a lot of money on the large N study.
I guess my answer is cross-sectional studies will never, ever get at the mechanisms of state changes. You need longitudinal, dense sampling type data to ever get at that. Cross-sectional large N studies just won't.
All right, so on that truly upbeat note, I think this is a great place to wrap up. Thank you so much to our panelists for your thoughtful responses, and thank you to our audience for those wonderful questions and for staying with us till the very end. Thank you.